Hello, this is Jacqueline Eckern with Addiction Hope, and today I am honored to be interviewing two leading doctors in the addiction field. Dr. Fuehrlein is the Associate Professor at Yale University School of Medicine. He's also the Director of the Psychiatric Emergency Room at the VA in Connecticut. Dr. Mark Gold has published 1,000 peer-reviewed articles and 20 books. He's also has been a professor at Yale University and now is a professor at Washington University in St. Louis. We are so privileged to have you with us, and I want to jump right in so we can make this as beneficial for the families and loved ones that are watching. Real quickly though, I'd like to just say welcome.
Thank you. Pleasure.
So, to start, Brian, can you tell us a bit about the work you do?
Sure. So, again, pleasure to be here. It's so great to be able to spread a message of addiction and hope to everybody. I'm the director of the Psychiatric Emergency Room, as you said, at VA Connecticut, and I'm also on the faculty at Yale. I am an addiction psychiatrist, which means that I did training in medical school and then psychiatry, and then did an extra year of training to learn about addiction. The work that I do in the psychiatric emergency room involves working with patients, veterans, because I work at the Veterans Hospital, veterans who have a psychiatric emergency of some type. And that could be a substance use disorder related emergency. Patients can come in with alcohol intoxication, with opiate use, with cocaine use, seeking detox or treatment for their withdrawal, seeking longer term treatment for their substance use. Or it could be non-substance use related presentations, such as a patient is having worsening PTSD symptoms, they're suicidal, or they attempted suicide, or they're psychotic, out of touch with reality. Sometimes veterans are brought in by police. Other times they present to the unit voluntarily seeking help, so we have a mix of patients that way. But the majority of our patients here in the emergency room present voluntarily seeking help, and often it's related to drugs or alcohol. We also have a variety of trainees here. So we have residents who are trainees in learning psychiatry. We have medical students who are obviously not necessarily going into psychiatry, but who are learning how to become a doctor. We have nursing students. We have nurse practitioner students. We have other residents of other specialties. So we have a variety of trainees here. So I like to have sort of multiple missions of what I do. One mission is to take care of veterans who have emergencies, psychiatric emergencies, and the other mission is to train the future doctors who are going to take care of these patients.
Thank you for your work serving our veterans. It's very admirable. So what are the patient profiles like of the folks you work with that are specifically dealing with opioid use disorder?
Yeah, so in general, and these are generalizations, there's always outliers for everything, but in general, we have two main populations of patients with opiate use disorders. One is a younger group, and this younger group got started on opiates, again, typically initially through pills, or either a prescription to them or pills from someone else. And then for whatever reason, the opiates were something that their brain got addicted to, whereas not everybody gets addicted to opiates, but for whatever reason, this group of people did. And they started on pain pills in some way, gradually got addicted to them, started buying them on the street, got addicted to heroin, started using heroin, sometimes even started injecting heroin. And now there's a lot of fentanyl use that we see as well. So we're going to see a lot of patients who come in. Heroin is sort of the thing we used to see all the time, and now it's fentanyl. So that's one group. That group of patients tends to be in the range of 20 to 30 years old in general. That's sort of the age range in which we see these patients who started with pills, eventually switched to heroin, and then often to fentanyl. That's a younger group. The other group that we tend, so that's one group of patients with opiates. So the other group that we tend to see tend to be a little bit older, and they have been on chronic opiate maintenance therapy for many, many, many years. So they've not necessarily been addicted with a pattern of obsessive compulsive use of a drug, or it overtaking their life. They have just simply been prescribed an opiate for many, many years. And over time, that has a larger and a larger effect on them, to the point that something is starting to go wrong. It could be that their other medications that they've been started on are interacting with the opiates. It could be that they fell. It could be that they are starting to abuse the opiates and take more than they're supposed to. It could be that they're nodding off while they're at home and their spouse is concerned about them. So there's a lot of reasons why at some point, after being on opiates for a long time, the doctor has decided, I don't think this is safe for you anymore. We need to take you off of these opiates. And that's an overwhelming process for some people who have been on opiates for a very long time. And often they send the patients to us in the psych ER to sort of get either detoxed off of opiates that they've been on for a while, or stabilized on something like a buprenorphine instead. But very different groups, right? The first group, which got started on opiates, quickly escalated to an addiction, to injecting possibly, and they're very young, to the group of sort of older veterans who have been on prescription opiates for many, many, many years. And now some aberrant thing has occurred and the doctor wants to try to take them off. And those are, and again, there's exceptions to these rules, but in general, these are the two main patient populations we see. The first group, the younger group, we see them all the time following overdoses, where patients will come in, they'll get resuscitated with Narcan or in the field, or they'll be here, and then we'll have an opportunity to try to intervene and try to help them following an overdose. It's also really common, that is much more common in that first group that I mentioned.
Thank you. Dr. Gold, what are your thoughts on this patient group and Brian's comments?
Well, I mean, first of all, I'm really happy to be on this Zoom event with Dr. Fuehrlein for many reasons. At the point in my career when I was at the University of Florida as a professor and distinguished professor, I remember when he was a first-year medical student. I remember his PhD work and thesis with friends and colleagues of mine. I probably was even on his committee. And remember very well his medical school graduation, as well as his choice for residency in psychiatry, as well as going to Yale for addiction psychiatry, and then coming back to Florida to work with us in the Florida Recovery Center before being recruited back to Yale. Brian, as an MD, PhD addiction psychiatrist, is maybe there are 3 of that breed that see patients. Most of the people that are this well trained turn up to be full-time research careers, writing grants. And so if you think about it, if you have an accidental overdose and end up in the Yale emergency department, and someone like Dr. Fuehrlein gets to see you, he'll get to determine a number of things. 1, is it accidental or on purpose? 2, is it due to fentanyl, because fentanyl has creeped into the drug supply and there's hardly any heroin to speak of anymore, and fentanyl being 100+ times more potent than heroin's more likely to cause an overdose where you stop breathing and where you're in imminent risk of death. And then he is skilled enough psychosocially to be able to use the opportunity to have you alive in front of him, and for him to say, you can't do this. Each of these is likely to kill you. This is serious and life-threatening. You've proven that to yourself. We had to resuscitate you. If you give somebody Naloxone, the reason you gave them Narcan was because you thought they were going to die or could easily die. And then what do you do next? He can initiate MAT treatment in the emergency department and do the complex psychiatric and addiction work that rarely you find in the United States.
Thank you. So, to both of you, what are we seeing with heroin and fentanyl as trends these days?
Yeah, I mean, I just published a paper on the rates of fentanyl use in the emergency room. Um, the data was from a year or two ago, so it's changed even since then. Um, but as Dr. Gold mentioned, it's becoming more and more fentanyl and less heroin. And what we're beginning to see is fentanyl is beginning to show up in a variety of places. For example, among our patients, we saw many patients who were not using opiates. They were using cocaine, but were testing positive for fentanyl in their urine. And when we would ask them, do you know you have fentanyl in your urine? They were mortified. Said, no, I don't want to die. Doesn't that stuff kill you? I thought I was using cocaine. And we said, well, you were using cocaine, but it looks like it had fentanyl in it. So a lot of times we're seeing patients who don't even know that they're using fentanyl, which, as Dr. Gold said, is so much more deadly than even other opiates like heroin, which is already deadly. It's so much more deadly than that because such a small amount can kill you. We're also seeing patients who are buying heroin and being told it's heroin, but when they use it, no, it's not heroin. They know it's fentanyl because they know the effect of the opiates and how the opiates make them feel. And what we're seeing is something really interesting where if someone, so I ask every patient who has an opiate use disorder, do you know anybody who's died of an overdose? I ask basically every patient that question who has opiate use. And so far, every single person has said yes, except for one person said no. But every other person has said yes. I do know at least one person who's died of an overdose. And I'll follow up with a few questions. And anecdotally, what I'm finding is that if you know someone who's died of an overdose, if you have an opiate use disorder yourself and you know someone who's died of an overdose, you might think that that person would try to avoid whatever that batch was that killed their friend, because that's obviously an unsafe, deadly batch. But what we're finding is if you ask the person, what was your reaction? They'll say, well, I wanted what my friend had. Even though I know it killed my friend, that's something that I wanted because I know that that's the powerful stuff. I don't want to die, but I want what's going to give me the best experience. And that powerful stuff is going to give me the best experience. The other thing we're seeing is it used to be that pills were safer because patients knew the doses, right? If you buy a 30 milligram oxy, you basically knew what you were getting. You know what it looks like, you know the color of it, you know the markings on it, and you know what a 30 does to you, and you know how it feels, and you know it's probably not going to kill you, and it's pretty safe. But now we're finding that manufacturers are making fentanyl look exactly like the pills. So people think they're buying a 30 milligram oxy, and they're actually getting a counterfeit oxy, which has some unknown amount of fentanyl in it. And in the user's mind, this is safe because it's a 30 milligram oxy. But in reality, it's not oxy at all. It's something designed to look like oxy, which really just contains fentanyl. And that's much cheaper for people to manufacture and to distribute on the street and sell than it is to actually get a 30 milligram oxy, which is a much more difficult endeavor on the street. So we're seeing fentanyl showing up in a variety of places. We're seeing it in other drugs like cocaine. We're seeing it basically heroin's almost being essentially replaced with fentanyl for the most part. And then we're even seeing pills, which we thought were reasonably safe. If you're using something, it's pills in the user's mind is reasonably safe. No, now this is even incredibly unsafe if this is fentanyl. So we're seeing a lot of overdoses. And as Dr. Gold said, you're trying to figure out, was this an intentional thing? Was this an accidental thing? And how does the patient perceive what happened? In other words, is this an opportunity to really break through with this person? If this is a 25-year-old kid, essentially, who nearly died of an overdose yesterday, can we use that as an opportunity to connect to that person and motivate them and convince them to get some help today? Because if they leave here, this is a very high risk situation for that person. So we're seeing, to answer your question, we're seeing fentanyl really showing up all over the place now.
That's really, both of those are really great insights. And just the only summary statement here for educational purposes is that illicit drugs and illicit drug sales are not supervised by the FDA. the composition of illicit drugs are only dependent on the manufacturer and distributor and independent of any regulation. So keep in mind that just like when people buy ecstasy, sometimes it has a variety of chemicals in it. It's not manufactured by a pharmaceutical company under the supervision of the FDA. So what Dr. Fuehrlein's saying is that if you buy drugs on the street, illicit drugs, rather than get a prescription and go to the pharmacy for a medication, you are liable to get anything because you're at risk. And you saw that, it was like all those people that overdosed at the Yale Green all at once. Everybody that overdosed, it seemed to be a contagious disease. You had, what, like over 100 people overdose in the center of town at once?
Yeah, we had a lot. It was made the national news because so many people were consuming something that came from somewhere that was causing them all kinds of problems.
The interesting thing for folks watching is all of us probably, or the majority, know someone who's died of an overdose. And even my 16-year-old son's friend since pre-K just died from thinking he was taking Oxycontin, took fentanyl, and we got the call the next day. Great family, tremendous promise for this boy. And they've gone on, that group, to try to lessen the stigma of addiction, to help people. And that leads me to my next question for both of you, which is how do we better educate families and patients about overdose prevention and treatment to save lives when an overdose occurs?
Is that for me?
Yeah. You go ahead, Dr. Gold.
Well, I was just going to say that in the Naloxone Narcan article that we did on Addiction Hope, we said that the data shows that people who develop an opioid use disorder are always at risk for overdose when they're out of treatment. So if they're in treatment with Dr. Fuehrlein, let's say, and they're in a medication-based treatment, they're coming in, they're giving urines and whatever, they're in a program. They're not at risk while they're on methadone or buprenorphine or Suboxone or Naltrexone. On the other hand, the minute they stop, they're at risk. Now you have, that's at-risk population. Then you have the at-risk population like that friend of your son's, which is the first-time user or the occasional user or the person whose drug supply changed, and they're at risk. So you see that the reemergence of the opioid deaths, and most people thought this was not going to happen. Like, how could the deaths go up even more? Well, you've identified here the major components. One, the drug supply has been changed. The heroin's been replaced by fentanyl. Fentanyl can be manufactured and is manufactured in Southeast Asia, in China, in India, now in Mexico, can be sent through the US mail. They don't need big ships. They don't need transshipment over borders. They just need a package in a post delivery. The second is that the drug supply for other illicits have been contaminated. Methamphetamine samples have been seen with fentanyl, as Dr. Fuehrlein said, cocaine samples. And there even is a Haight-Ashbury Free Clinic report of someone getting street cannabis who believed they overdosed because it was sprinkled. Whether that's true or not, we don't know, but we heard from Dr. Smith that they were reversed with naloxone. That's the second trend. The drug supplies changed. The third is that our patients are afraid to come to the emergency department. And Dr. Fuehrlein should talk about this, but both psychiatric emergency room visits are down and addiction visits are down, even though calls to suicide hotlines are up and overdoses are up. People are afraid. They're more afraid of catching COVID than they are of their disease of addiction, which is likely to kill them. And that's also changed our ability to treat people in an ongoing basis. Many people who were successfully managed with buprenorphine or with Suboxone or with injectable naltrexone have stopped going to their doctor's offices, and they're at risk too. So almost everything seems to have come together in a perfect storm that makes everything that we thought of changed. And the only thing I tell everyone every time is, if you know somebody has an opioid use disorder, carry naloxone or Narcan. And if you have a loved one, you should have it in the house. That overdose just seems to be a consequence of being outside of treatment with an experienced professional like Dr. Fuehrlein.
Yeah, so I'll get to, I want to mention a couple things about COVID. But first, when we talk about sort of reducing the chance of overdose, harm reduction or overdose prevention, a couple of things, as Dr. Gold said, we want someone, so don't, if these are the things I'm going to educate my patient about, don't use alone. So if you're alone and you overdose, there's no one to help you. And who's ever with you should have access to naloxone and know how to use it, just in case something happens. So those are two kind of first critical things. If a relapse occurs following a period of sobriety or following a period of abstinence, the chance of an overdose is more likely because that person has lost tolerance, which means that if someone used to take a certain amount of fentanyl or heroin or opiates, any opiate, and then loses their tolerance because they've been abstinent for a period of time, and then takes the same dose they used to take when they had tolerance, they're more likely to die of an overdose because they've lost tolerance. So what we say is don't pick up where you left off, meaning if you used to use a certain amount, don't use that certain amount again following a period of abstinence. That's why we see when people are released from incarceration, that's a very high risk time because people have lost abstinence. They've lost tolerance due to abstinence. And if there's no treatment done while they're incarcerated, the chance that they're going to relapse upon release is very high because there hasn't been any treatment that's been given to them in the time that they've been incarcerated. The other time that we see as a high-risk situation is following a period of treatment. If someone is in treatment for 30 days and they've been sober, sometimes people relapse. And again, don't pick up where you left off. Also, use from the same supplier. And for all the reasons that we mentioned, if you're used to buying from one person and these are the opiates that you get routinely, you know how they affect you. And if you switch to a different provider, you don't know what that person has, you don't know how it's going to affect you, and you could die of an overdose. Also, not to mix substances. So if you're going to use opiates, don't use benzodiazepines, which is Xanax and Klonopin and Valium and Ativan. Don't take those, and don't drink alcohol. That combination of opiates and benzos or opiates and alcohol is particularly deadly. So we obviously want our patients to be abstinent and sober and in recovery and in treatment. But if you're talking about a harm reduction or overdose prevention approach, these are the type of things that I'm going to educate my patients about before they leave. Don't pick up where you left off, have Narcan, don't use alone, et cetera. These are the things that I'm going to educate my patients about. So strictly harm reduction. To get to Dr. Gold's point about COVID, we're seeing a couple different things. We saw a dramatic decrease in presentations in March and April and into May. We suspect people were afraid to come to the hospital. And we saw it across the board on the medical side and the psych side. People are having MIs at home, they're having heart attacks at home, afraid to get COVID, but they're like dying at home. It's unbelievable. And your opiate use disorder, if you're injecting fentanyl, is far more likely to kill you than COVID. COVID is important, obviously. We want people to take care of their health, but if you have an opiate use disorder, please come to the hospital. The other thing to keep in mind, the hospitals are pretty safe right now. We're testing all of our patients for COVID. We all have face masks. We have shields. Face shields. We are an incredibly sterile environment here at the hospital. So we really want everybody to come in. But we saw a dramatic decrease in presentations, and that those patients who were afraid to come in lost a lot of their resources. So methadone clinics had to reduce the number of days they were seeing patients. A lot of Suboxone, buprenorphine providers are switching to phone only, and it was difficult for patients to engage only over the phone at the last minute. Sometimes providers were sick themselves and couldn't come into work and had to miss appointments with their patients. AA and NA meetings had been switched to virtual or canceled because of the risk of COVID. So there were a variety of reasons why the patients who were afraid to come into the hospital are also losing the resources they were counting on to stay sober in the first place. So you're having risk of relapse in conjunction with a fear of coming to the hospital, which was really putting our patients in a very dangerous situation. We're seeing the volume pick back up. We're seeing patients starting to come back in. We're seeing resources open. I'm in Connecticut. I know other parts of the country, at least currently, are not. They're not doing as well with COVID. So some of these things are still closed for them. So there's a variety of issues related to COVID. So hopefully that answered your questions. I don't know if there's anything else there. I was rambling.
Yes, very helpful, Dr. Fuehrlein. Dr. Gold, do you remember when you started treating patients with Naltrexone? Can you tell us about it?
You can see how busy Dr. Fuehrlein is.
I know.
Basically, if you're running the emergency, no, if you're running an emergency room, there's an emergency like every other minute. And the other thing that people don't realize is, like in these academic medical centers, somebody's seeing the patient. It's not like patients are going unseen, but they get to a point and they go, I could use help from an expert. Then they call him. So keep in mind that if you have to pick up the phone, put us on mute, and come back and join us. We like the idea that you're actively saving people's lives while we're on this Zoom. People have to understand what a great commitment it is. This is the Peace Corps of Medicine. I know I said this to him when he was in training, and people are always saying, what should I go into and what should I do? And I'm sure I told them more than once that addiction psychiatry needs people in it who are trained in neuroscience and understand the brain, and it helps us. But anyway, for me, I gave Naloxone, Narcan in the Yale New Haven emergency room in 1975. It was in an ampule. I was made out of glass. And we had that time Southeast Asian heroin in New Haven. And you had to pop open the Naloxone vial and then draw out in a syringe the Naloxone, then find a vein on a person who's near dead, and then inject it into the vein. And so a number of things that I remember after all this time. One, I remember always cutting my hands. We didn't really have gloves. We were just reacting to the emergency to save the person's life. And we were popping vials open and drawing Naloxone and cutting ourselves. And luckily, I didn't catch anything that I know of anyway. The second thing I learned was that you could miss a vein and still save the patient. So sometimes they had no veins, and just the spread of it subcutaneously was good enough to revive them. The third thing that I learned was that the patients were unlike people who you revived with a Heimlich maneuver or who you revived with CPR or cardioversion, in that they were the least grateful of those 4 patients. So in an emergency department, you'll see people who have airway obstructions. You get the thing out of their airway, they breathe, and they go, thank you, doctor, or thank you, team, for helping to save me. You see someone who's had a cardiac arrhythmia, and you give them CPR, and they recover, and they thank the whole team. They might even like make a donation to the hospital. They're so excited. But for Naloxone, when we gave that, the patients were often not excited. Sometimes they were mad at you. And occasionally they thought that you had interrupted their high, that they weren't going to die, but somehow you decided that they were going to die and you ruined the effect that they were having on the drug. So we tell people going to the emergency room, like Dr. Fuehrlein, that you're doing this because 1 year or 5 years from that rescue, the person will be grateful. It's not for the gratitude that we do it. We know it's the right thing to do. And then we try to facilitate treatment. So we gave people Naloxone in 75. And we had no other treatment at that time other than methadone. Experimentally, we got Naltrexone at Yale, and we gave that to people, but it was a pill. So as a pill, they would have to take it every day or 3 times a week. And what we learned out of that was, as time went on, they would convince themselves they didn't need to take it. So they would stop, and then they would overdose again. So naltrexone, while we gave it, the only people that we could show it worked on were doctors, because their license bureau would force them to take it. It was really coercive treatment. Somebody would say in the Board of Medicine, if you don't take this, if you don't follow your treatment plan, you can't be a doctor in our state. Well, that was very powerful. And also some people that worked in financial industry. They were drug-free occupations, and they would manage to ensure that the person would comply with the treatment. So really, except for those rare groups, naltrexone wasn't a particularly viable treatment compared to opioids until you had injectable, which could last one injection for 30 days. And at Yale today, they use that treatment on people who are willing to be treated and maybe don't want to come to clinic. They have a homeless project, and maybe for people who've progressed in their motivation, but I'd say that the first go treatments are buprenorphine, Suboxone.
What is the
Yeah.
Oh, go ahead, Dr.
No, I was
Fuehrlein.
just going to add, so as Dr. Gold is saying, there's the naloxone, which is the overdose rescue, which is life-saving, is not treatment for the underlying opiate use disorder diagnosis. And you can think of it as, if you want to use an example like Dr. Gold mentioned, if someone has a heart arrhythmia, they may need to be shocked to have their life saved because they're having an arrhythmia, but they still have an underlying heart condition and they need to take medication to prevent this arrhythmia again. So they need this medication for maintenance, for treatment. If you just shocked them and saved their life and ignored the fact that they still have an underlying heart problem and you didn't give them treatment for the heart problem, the chances that they're going to again need a shock down the road or might die is pretty high because you haven't treated this underlying problem. So when patients come to us following an overdose, saving their life with Narcan, administering that and bringing them back is one thing. But unless we address this underlying opiate use disorder as a diagnosis, which they continue to have even after they've been resuscitated, that's a separate thing that we have to address. And if we don't, chances are they're going to use again and possibly overdose again. And as Dr. Gold mentioned, the treatments, buprenorphine or Suboxone, methadone, and then Vivitrol, which is the extended release injection that Dr. Gold is talking about. The good news with all this is those 3 medications are incredibly effective for opiate use disorder. So our goal in the emergency room that I run is to get every single patient with an opiate use disorder, whether they needed resuscitation with Narcan or not. If they have an opiate use disorder, we try to get them on a maintenance therapy. And usually it's buprenorphine, but often our patients get started on methadone in the methadone clinic here. We start buprenorphine ourselves in the emergency room and have a whole process by which to get them initiated and stabilized on it. And same with the extended release naltrexone. We have a process to try to do that as well. That's a little more difficult, but we can get our patients on one of those 3 medications pretty much every time, as long as the patient's agreeable. And we do everything that we can do to get the patients to agree because of the nature of opiate use disorder and how effective these maintenance medications are for opiate use disorder. So it's not all bad news. It's good, really good news is that these medications are super helpful. And if we can get patients stabilized on these medications, the risk of overdose, the risk of death, the risk of relapse goes way down.
So Vivitrol, why is that such a big deal?
So basically that's the injectable long-acting naltrexone. And the thing about it is, you can think of it as a long-acting naloxone or Narcan, but it shows you how similar different drugs are. So in this case, Vivitrol is approved by the FDA for the prevention of relapse in alcohol use disorder, and it's approved for the prevention of relapse and craving, in opioid use disorder. Most people wouldn't think, if you had to guess two drugs and say, is it possible that one medication is safe and effective for two addictions? Guess the two addictions. I doubt very many people would guess alcohol and opioids, but that's the approval. We used it at Florida for people who were anesthesiologists with opioid use disorder and wanted to return to the operating room because for some reason that's not well known, but it's being studied by researchers at the University of Pennsylvania. Naltrexone blocks the brain's response to cues. So when an anesthesiologist would see a morphine bottle or see the OR, that is a cue that triggers dopamine in their brain. It's like foreplay, and it gets them into the mindset of using and craving. For some reason, naltrexone is particularly good at preventing that. So that's been successfully used. Vivitrol is the, if you would, the brand name, but there is no other injectable long-acting naltrexone. One injection works for 30 days. So you could say if your goal was to get a person to be opioid free for 12 months and you had them detoxified or they weren't addicted, you'd say, well, you have to come in for 12 shots once a month for the year. Or if your goal was 90 meetings in 90 days, it would have to be 3 shots. That's what the treatment advantage is. But as Dr. Fuehrlein said, because you have to be detoxified to take your first dose safely, the initial onset period for Suboxone, more people stay on it than stay on the naltrexone injectable. On the other hand, in the XBOT study, it says as long as people are detox, the treatments are roughly equivalent. And I don't think it really matters which treatment. There's a lot of personal choice in this and a lot of access issues, cost issues. But I do think it's important, and you do a great public service on Addiction Hope to tell people there's hope. We have 3 safe and effective FDA approved treatments that cut overdose deaths, cut relapse, and improve a person's ability to function and re-enter society. And that's wonderful. If you compare that, for example, to methamphetamine, we have none. No safe and effective treatments. Cocaine, none. No safe and effective treatments. Cannabis use disorder, probably none. They're working on a variety of them, but really, for alcohol use disorder and opioid use disorder, we have treatments that work. We just need people to take them.
Absolutely. So a couple of questions as we wrap up. Both of you have mentioned the treatment of professionals, fellow physicians, pilots. If someone's watching today, how can they confidentially get treatment and not hinder their career long-term?
You could call him. He'll help you.
Call Dr. Fuehrlein?
He will. I mean, like, you call an expert. I think somebody who's board certified in addiction medicine or addiction psychiatry, you go for a consult. It's very important that you don't diagnose yourself. So Dr. Fuehrlein and I know too many impaired health professionals. There's so many that one thing I've been impressed with, and I used to do a lot of this work myself, being on the PRN board in Florida, was that the person's description of themselves is very different than the people who are working with them, is very different than the description their spouse or partner will give, is very different than what you decide when you evaluate them. And oftentimes they need a 2 or 3 day evaluation just to peel the onion. They're very complicated. They have a lot of psychiatric problems, and it's very important to get history and information from a variety of people. And then you need testing. Without testing, um, doctors are difficult to evaluate, period. But testing helps you as much as anything. Just talking to the doctor is not going to be as helpful as you might like, because over time they become very deceptive and tangential and less forthcoming. Even I don't know if Dr. Fuehrlein's ever had this experience, but I once had to go to an on-call room and see a doctor that had overdosed. And even on that rescue, the doctor, because of the license fears and other fears, denied anything and everything.
Yeah, so well, I'll just add a couple of things. Dr. Gold is certainly an expert in this, having been at the Florida Recovery Center and the chairman there, and Dr. Teitelbaum was one of my old mentors, as Dr. Gold knows very well. One of his mentees was one of my mentors. This was sort of his livelihood, was treating impaired professionals, and I did a lot of work in Florida with this. Work is usually the last to go. So we, as speaking for physicians, we have a remarkable ability to hold work together despite the world crumbling around us. We have an ability to hold together our jobs and our work, even though everything else is falling apart. If work is starting to become affected, the process of the addiction is probably fairly advanced at that point, and usually that person will need some help. I don't know the exact rates, but the rates of addiction among licensed professionals as a whole is usually considered to be a bit higher than among the average population. So you're talking about 1 in 5, 1 in 4 even I've seen. So you're talking about a lot. So if you walk around a hospital, you're very likely to encounter someone who at some point is having a substance use disorder. It's just very common, and work is usually the last to go. But the good news, again, is that professionals, and not just physicians, but all licensed professionals, which includes a lot of people, we have added incentive to stay sober. As Dr. Gold mentioned, as long as you take your buprenorphine, you can have your license back. Most licensing agencies spend a lot of time, effort, and money on licensing their people, and do not want to throw away those licenses and fire people and kick people out of whatever profession they're in because they have a medical issue. Most of the time, licensing agencies encourage their licensees to get help and to get treatment. So we, as licensed professionals, actually often have better access to treatment because we have this agency that is overseeing us and cares about us and wants us to get sober and wants us to keep working and contributing. So my advice, if someone is a licensed professional and is struggling at work, is don't put people's lives at risk. Recognize that there's a problem and get an evaluation. And sometimes the evaluation is you can safely work doing this or this or this. Other times the result of the evaluation is no, you need intense treatment because things are going wrong in your life. And you have to get that evaluation. And if you're licensed, there's a mechanism to do that. And if I fell into an addiction now, I can call the Connecticut State Board. I can explain to them I'm having a problem. They could make recommendations, or I could call one of my colleagues for a recommendation for an assessment. And I could go somewhere and have an assessment done and follow the recommendations of that professional who made that recommendation. And if I do that, the chance that I'm going to maintain my livelihood, maintain my license, and get sober is pretty high because there's a pretty good track record of these programs out there for impaired professionals. But we have to get that person into that evaluation and motivate them to recognize that there's problems going on. And as Dr. Gold said, it's not always as clear cut to that individual as it is to everyone around them.
I would like to offer that anyone can use the Contact Us page at Addiction Hope, and we will confidentially try to put you in contact with the right folks to protect your privacy and help you find the top care that you can. And I can also always, on special occasion, see if I could forward something to Dr. Gold or Dr. Fuehrlein for consideration. My last question for you, doctors, is the veteran population. We're so grateful to these heroes that have served our country. And Dr. Fuehrlein, I just commend you for your dedication to this group. Thank you. what can we do to bring greater attention to their needs and their care so that it improves moving forward?
Yeah, so I think I'll tell you a quick story that has nothing to do with veterans, but I just think it's fascinating. I speak at high schools. Someone that I know lost a teenager of an overdose and invited me to speak at high schools about sort of opiates and opiate use disorder. And this person had far reach. They were in contact with the town first selectman, which is sort of like the mayor of the town, and knew the other high-ranking officials in the area, and put out this big sort of social media campaign trying to attract all these family members and parents. It was geared for the parents of the kids, to bring parents into the auditorium and have a big sort of like information session about what to look for with your children with opiates. And this was a major high school with a lot of people, a lot of kids. And I think we had 5 parents show up. And all 5 parents already had experience with their child having a problem with drugs or with alcohol. All the others either ignored the problem or were unaware of a problem or thought that their kid would never have a problem. And one of the organizers said to me, if this was this exact same thing that we were organizing, but the topic was how do you get your kid into the best college, the auditorium would have been packed. But because we were talking about something like drugs, nobody wanted to believe that this would ever happen to them or to their child. And it's incredible that something so pervasive and so important, there's still such a stigma attached to it that nobody wants to acknowledge that this could ever happen in their family and to them. And that's unfortunate because this is a treatable illness like everything else. And to get to your question about veterans, this is the good news about veterans, is that everybody loves veterans. Everybody loves, you go to a baseball game, let's honor the veteran of the day. Every city you go to, there's a war memorial. Everybody loves veterans. And I think this is a good model for us being able to break through some of that stigma. Because if a veteran has an opiate use disorder or has a mental health condition, often they're seen as veterans first. And everyone loves veterans. And we want to get this veteran help. But if that same person was not a veteran, often we now see that person, now their identity is the drug addict, which is obviously not what we want, or the person with mental illness, which is a stigmatized condition. And that is, same 2 people, one is a veteran, one isn't, otherwise identical lives. In general, the veteran gets a lot more love and attention than the others. Now, having said that, there's obviously still things that we need to do to help veterans also. But I really wish that we could break down that barrier, which is let's not see the person as someone with a mental health problem or see this person as someone with an opiate use disorder or some derogatory term for that person like drug addict. It should instead be, this is a person, we care about this person, and let's get this person some help. And I see that a lot at the VA. I see that where this is a veteran, I want to get this person help. Everything else about them is there, but first and foremost, they're a person and a veteran, and they served our country, and we love them, and we honor them, and we want to help them. But you don't have to have been a veteran you shouldn't have to have been a veteran to feel the same way about other people. Let's get this person some help. Let's love them. Let's honor them. Let's do what we need to do to get this person help, whether they're a veteran or not. In many ways, the VA can be a model for that. So I think there's some hope and some good news with that, but it's very difficult to break down these barriers and the stigma that goes along with mental illness and with substance use disorders.
Dr. Gold, did you have any final comments to add?
Well, I appreciate the Addiction Hope, like focusing on this and getting the word out. I think people have to try to be honest with themselves too. When someone overdoses, some of the celebrity overdoses have been public and they've described themselves and what's happened to them. I know I wrote about one for you. She's engaged. You first have to save the person's life. You then have to work on helping them to rebuild their life. But you shouldn't forget from a prevention point of view that they didn't start with opioids. But people had objections to the gateway hypothesis. That was Bob DuPont's hypothesis. But the gateway data says that typically people train their brain to respond to drugs of abuse by smoking cigarettes, drinking alcohol, or smoking cannabis while they're children or teenagers. That brain training makes the brain respond to drugs in a way that's somewhat different than if they would have never done that. And that's really why the main prevention message from Nora Volkoff or from NIDA is always, if you're going to start experimenting, quote unquote, with drugs, or you think recreational drug use is something that you'd like to try, think 30 rather than 13. Think when the brain is developed rather than developing. And so it's so unusual to find someone that does not have a gateway drug event just because the brain works like that. And my last prevention message is keep in mind, smoking is injection without a needle. So any smoking event is, in essence, an injection event as far as the brain is concerned. So training the people say, well, cigarettes are the most addicting drug. And I would say, well, in my day, when I was doing tobacco research, people had how many cigarettes in a pack? How many packs per day? We had veterans at 3 packs a day. And we'd say, well, how many puffs per cigarette? Each puff was an injection. It was almost as if they were injecting themselves hundreds of times a day. So if smoking is injection and smoking is brain training, and brain training is what causes the progressive aspect of drug switching as you become tolerant and as the brain wants additional stimulus. It's a real problem to see so many daily drug users among the teenagers, 6th and 8th graders in the University of Michigan's latest survey.
An important message, very concerning. We really appreciate your time. I want the viewers to know that we have several articles about the medications discussed today featured on Addiction Hope, and Dr. Gold generously writes for us. So I hope you'll check out his material. He is renowned, as is Dr. Fuehrlein. We are so grateful for your time today.
Well, thank
you.
I would say
My
that
pleasure.
Dr. Fuehrlein also peer-reviewed a couple of those articles, because even if you're a full and distinguished professor and you train somebody who trained somebody and many other people, peer review is always a good thing. So you're never too full of yourself.
Thank you, Dr. Gold. You are wonderful and charming. Thank you for your time too, Dr. Fuehrlein.
Yeah, thank you. Thank you, Dr. Gold. Obviously, you're my mentor for many, many years. I wouldn't be here if you weren't where you were at all those years. So thank you, and I appreciate the opportunity to be here. Encourage your loved ones to get help. If there's a problem, there's plenty of professionals out there who can help you. So again, thank you very much.